kind of follow what's going on. This will become your Bible as you start working with E&M codes in terms of a summary sheet.
It's not too high. It's my head in the way.
Okay, now, just a few learning tips. This is a lot to learn. It's going to require a lot of effort. Hopefully our brains have been caffeinated enough now that we can start absorbing. And it's going to take multiple repetitions to fully understand. Every time I go through this, I'm finding I pick up another thing that it suddenly makes sense for me. So don't be overwhelmed that you don't get it right away. It will take time. Now the first step is to learn the system, not the details. Again, we're going to try to get the gestalt of the system, and then we'll go into the micromanagement components of it. And we'll use these, what we call cheat sheets, but we prefer the name guide, actually, and templates to help you learn and follow. And once you start doing it, you'll figure out which codes fit your practice needs best, and you'll figure out your documentation styles based on your own style. We'll give you some guides. We're in the process of, at least at ACAP, of developing some template guides that could be incorporated either into your own written notes, or a lot of this is a project that's part of our ENR task force development that you could then get programmed into your ENR depending on how you like to record your notes. So that will be coming. No. We were too busy getting this. I'm in the process of trying to write those now with another colleague. Now, what you'll end up doing is memorizing, as I said before, the couple of codes that you'll be using the most, your bread and butter codes, but that'll give you a schema if you were going to go to a higher or lower level once you get a couple codes down. So, what are E&M codes? These are the series which we call 99XXX, the last 3 digits help categorize them, codes that all medical providers will use. What they describe the evaluation, which is the collecting of data, and the examination and management, which goes into the further assessments of the treatment, your treatment planning, your prescriptions, and any other medical services that this patient requires. These can be reported in addition to other procedures unless it's specifically restricted. There's some codes that say you cannot report with another E&M. And those are in your, the CPT manual is very clear on that. So why should we use it? Well, basically, they pay more. And for CMS, at least, you're not going to have a choice after January 1st, 2013. A lot of the third-party payers have already told us that they're prepared to go as of January 1st. A few of them, Magellan, as usual, does everything to make our life difficult. And take that out of the YouTube, please. Off the record.
What did Magellan say?
Right there.
Magellan, well, we can't get, okay, sorry. So
not all the companies will be using these for
most of them will be, because as Medicare goes, most of them follow suit. It's a question of how they choose to reimburse and what they pick and choose, and we have no control over that.
How will you know? In other words, will they inform you?
Yeah. Yeah, when you send in a code and they'll send it back, they'll reject it, they'll say this, it's a game you'll have to play. And, I think...
How about the other way around? Suppose you use the new code, might they reject it also, saying that we haven't...
Well, you may then have to fight for it. Well, I think at the end we'll try to go over strategies on dealing with third parties, including writing lots of letters, which we have some templates which we'll send out. But anyway, let's look at the comparison. Now, this is going to be based on 2012 data. So what you'll see, 90862 paid you $57.76 Medicare dollars. Click again. Okay, if you use 99213 and 99214, which we think covers the bulk of psychiatric medication management, you would get $68.97 or $102.27 for basically delivering the same service. Click Okay. Now, if we look at the evaluation codes, again, in 2012 dollars, you got $153.91 for 90801 and a little bit more for 90802. But if you look at 99204, which is typically a 45-minute session, probably not as complex as most of our initial evaluations, you still got a little bit less. It's almost the same. And for 99205, which is probably the most typical correlation, you got $197. Now, in companies that would take consultation codes, you get even more, but Medicare doesn't take consultation. They eliminated those a few years ago. Some of your third-party carriers still take consultation, so that is actually your best code to use in terms of dollars and cents. The other codes really are your hospital visit codes. And the 99222, 99223, those are the codes people use for hospitalized patients. Now, what are our risks? Of course, everybody's concerned. They're a little bit more complicated to code, yeah, but it's something that you can learn and become familiar with. Remember, all other doctors do it, so can you. And you'll learn what are the essential documentation points you have to have. It's very easy to miscode, which is why we want you to be familiar with what makes up these codes so you won't be caught miscoding. And if you start miscoding, you know, that's the red flag for the auditors, so we're trying to help you prevent that. And remember, they can come after you for undercoding as well as upcoding. So some people are, because they're afraid of upcoding, do what we call downcode, and they say, no, you're not coding this right, you're supposed to code it this. You know, they'll come after you for anything. So we really want you to know how to do it right. So the reason for the documentation is it facilitates the ability to evaluate and plan for the patient's immediate treatment and to monitor their health care over time. And it serves as a communication vehicle and continuity of care among healthcare professionals. So that somebody should be able to look at your note and figure out what's going on with this patient. It makes sense out of your plan. And this helps them in utilization review and quality care. And then it allows you to collect data that can be useful for other researchers or purposes. So there's a reason to have good documentation. And then this also helps with your claim payments. If they say we want to see your note to see if you documented it, if your notes are very clear and consistent and go along with the patient's needs, they're not going to give you a hard time. So what's the E&M documentation? Well, CMS came up with what they called a general multi-system examination in '95, and of course it freaked out psychiatrists because that meant we were supposed to go back to our medical school days and do a complete physical. Then in 1997, they came up with they revised this and they had the general multi-system exam and what they called single system exams, of which psychiatry does have a single system psychiatric exam, and that's the one you'll be using for your documentation. And we'll go into what those fine points are. And then they came up with some voluntary auditing guidelines to guide you into what you need to put in your note to qualify for that exam. So again, we say beware of the auditors, as we said before, upcoding. They get you. Downcoding, they'll get you. And there's big fines in this stuff too, so you really have to be careful. And you have to match the criteria. And what we're really looking at on this, as we'll be going over, is it has to be a combination of medical decision making and medical need. You can't pad your code just because you figure if I do more things, I can get a higher code. There has to be need to do more things. And it has to go along with what the complexity of the medical decision making is for that patient. Go on. Okay. Now our red flags is if you consistently use the highest level code. Like if you're coding everybody 99215, they're going to get suspicious because not everybody should be such a high complex patient in a typical practice. Or if you only use one code, if you say, well, everything I do is a 99213, Okay, maybe that's mostly what you do, but I'm sure there's some people in there who are more complex than that and who would qualify for 99214. So this is what you have to look at. What am I doing for this patient? And what does it, what fits best in terms of the level of complexity of this patient and the level of decision making I have to make? And this will come naturally as you get used to the codes. So, like many of our codes, they're divided in families. For E&M, we have site of service, which is office, hospital, nursing facility, or emergency department. And patient status, they're either new or they're established. In the hospital work, you have day of discharge codes, and then you have the consultation codes, which aren't reimbursed by Medicare, but third-party people still reimburse them.
What is consultation, and how does that compare to seeing someone once and you don't work anymore with them?
Consultation requires a referral from a healthcare provider for a specific reason, and they're supposed to note it in your chart and send you a referral note. And you have to have a report. You have to generate a report. Doesn't say anything about mailing a report. You just have to have a report in your chart that says it's a consultation. Most of us would get a consultation from somebody, we'd probably at least send them a note. But
just a quick question. I don't know if you're going to go on this later, but are there code listed some places for where office code is versus hospital code?
yeah. I mean, it's actually on the chart. I'll show you how to read the chart.
Okay.
Okay. Anyway, so now if we look at levels of codes, most of them have 3 to 5 levels, which really reflect medical decision making. And the level is always designated by the last 5th digit. That tells you what level you're at in that family. And the level is determined primarily by what we call key components. And the key components are basically what you have to do to code that. The levels can also be coded on time. Again, this is CPT time rule stuff. If you meet at least 50% of the typical time, and you spend the typical time. In other words, 99215, for example, typical time is 40 minutes on that. So if you're spending 40 minutes talking to a patient, even though maybe it wasn't a complex patient, but what that patient needed at the time was for you to talk to them, educate them, etc., you could code the highest level. You just have to make sure you document that you spent 40 minutes with this patient and you didn't do much, you don't have to do much of your history and or exam because you met the code requirements in time. Okay, so let's go over our key components because this is going to be the most important thing you're going to be looking at in terms of the combining E&M with your psychotherapy. You have to look at the nature of your presenting problem, your history, your examination, and your medical decision making. And then what goes in the medical decision making is this counseling coordination of care, and that may be where your time factors are. And then time. Okay, let's talk about history. Okay, history consists of chief complaint, your history of present illness, and there are 8 elements in it, or you have to, you can do your history based on your number of chronic or inactive problems. So if you have a patient who has 2 to 3 ongoing problems, depression, anxiety, depression, underlying personality disorder, substance abuse, those count as problems. So you can just say patient here for follow-up of these problems and list your problems, and you've basically met your history requirements. Then you have your, your past family social, it's all medical school stuff. And then you have your review of systems again. And there are 14 core systems, organ systems that you can look at, but you don't need every system every time. So let's look at our physical examination now. We're using the psychiatric single system. And there are 3 basic areas you look at. One is what's called constitutional. The other is going to be your psychiatric, which is really just CMS's organization of a standard mental status exam. They do it a little differently than most of us learn, but it's easily adaptable. And then we have to do something from one other area called and we pick musculoskeletal just because it's simple. Go on. And then we have medical decision making. And this is where the meat of it is. And this is something, as you're looking at your patient, you'll kind of decide where you're going even as you're seeing the patient.
I'm sorry, am I misunderstanding you? Are they mandating us to do physical exams?
Yes.
Yeah, but our physical exam is a psychiatric exam.
A mental status exam?
Yeah, yeah, that's our
Only
physical.
One of these needs to be met.
Yeah, yeah, and other than a new patient, you either do history or physical. Except in one other exception I'll get to.
But the physical is the mental status exam.
Yeah, but with a couple of other additions, but we'll get into that.
Okay.
It's nothing that you probably don't already do.
Is all of this for new patients?
Either. I mean, it's a different criteria. New patients, you need all three of the components. Established patients, you're going to need two of them. We're going into that, okay? So let's take a quick look at medical decision making. And again, this is going to be based on your number of diagnoses or management options. So the more complicated your patient is, multiple diagnoses, it's going to be a higher level. The more options you have to include in your treatment planning, higher level. The amount and complexity of the data to be reviewed. You know, if you have to review a lot of reports, testing that you've done, that adds to your complexity. And then, most importantly, your risk of complications, morbidity, mortality, and this is probably becomes your primary driver. You have a patient who's suicidal, self-injuring, self-starvation, doing something that's endangering their health, that's putting you in the highest risk. So when you get those patients, you're at a high-level code automatically. And that risk and mortality is based either on what the presenting problem is, i.e. suicidal. Diagnostic procedures, probably we don't do anything diagnostically that's going to be get us into that category. And management options, well, yeah, most of our patients are complex. We have a lot of management options, so that might drive your code to a higher level as well. So let's look at key components of history. Now there are 4 of them, and this, again, if you follow this chart, we're in this section, okay? The top paragraph, actually, is going to get your history. Okay, so chief complaint, we all know that. Then you do your history of present illness, and your past family social, and your review assistance. So those are the 4 key things that make up the history. Now let's look at chief complaint. It's only one level of it, but it's required for every visit. It could be, it's the reason for the visit, and it could be from the provider perspective. You say follow-up exam for depression or patient evaluation for depression, anxiety, whatever. Or it can be from the patient's perspective. I feel sad all the time, or those of us in child and adolescent frequently, my mother made me come. Okay, so now when we look at the history, there are 8 possible elements, and they describe the patient's present illness from the first signs of symptom to the current status since the last visit. Now, let's look at the 8 elements. Okay, we have location, which for psychiatric purposes, we usually say emotional, behavioral, I guess you could say supratentorial, whatever. There's no real official word for it because it's too abstract. So we just have been using emotional, behavioral as a location. You have the quality, you know, mild, moderate, severe, and you have the severity, and you have duration, how long it's been lasting. You have timing, things that might trigger it. You have the context, situations that might trigger it. You have modifying factors, things that somebody might do that could affect it. And you have associated signs and symptoms. What other things happen when the patient has this complaint? Okay, let's look at an example. Okay, this is a 1-sentence example. The patient reports intermittent emotional problems of moderate sadness starting with a romantic breakup 6 months ago, now more so when alone, and associated with poor sleep and appetite. click again. Okay, so the little numbers, intermittent is your timing. Emotional is your location. Moderate is your severity. After the breakup, or sadness is the quality. After the breakup becomes the context. How long? The duration is 6 months. The modifying factors is when alone. And the associated signs of symptoms, poor sleep and appetite. One sentence, you've documented all 8 elements. Okay? This may not be the best written one, but you can come up with your own template. Yeah.
So, are you saying that we have to qualify specifically, say, emotional problems for that location for that to be accurate, or?
You don't need all 8 elements.
Oh.
Okay? What I'm trying to do is say there are ways you can do it that would mean an element. Okay? So, okay, for HPI, it could be brief, which you need 1 to 3 elements. Okay? So very low level, or you can do the status of 1 to 2 inactive conditions. So a lot of these people, you're just going to do it by stating what you're treating them for. Okay, you can do extended, which you just have to do 4 elements, minimum. Or the status at least 3 chronic conditions. Okay? So for past family social, for the past history, you look at illnesses, operations, injuries, allergies, immunizations, nutritional dietary status, any treatments they've had since your last visit. Maybe they've had nothing. All you have to do is no change in medical history since last visit. For family history, you look at medical and psychiatric events in the patient's family. Some may have come from your initial history. You may have just found out that somebody reports, gee, I just found out my uncle had bipolar disorder, or my grandmother had a severe anxiety disorder. That may be pertinent to that you're treating a patient with a mood disorder or anxiety disorder. That's pertinent information, so you could add that. Social history, again, very easy. It's either past or current activities for kids. They're in school, they're in what grade, they're participating in soccer. You know, for adults, working, alcohol, substance abuse, marital issues, all that can go in social. I think we got all that. Okay. Now, what are requirements for these? Okay, for pertinent, and again, pertinent will be a low-level code, as you will see. We have an item from one area. Okay? If you're doing a complete evaluation of an established patient, you have to have an item for each area, from two of the 3 areas, I should say. Okay? And that would be from a new patient, you have to have them from all 3 areas. Okay, so review of systems. Okay, you have constitutional, which is something you do all the time. You know, you describe your patient, comes in looking disheveled. Or you would do your vital signs. You could do 3 vital signs: pulse, blood pressure, respirations. You know, many of your patients on meds, you're taking the pulse, blood pressure. Very easy to do respirations. You know, for kids on stimulants, weighing them, measuring them, maybe checking their pulse, blood pressure. So these are things you probably should be doing medically that you just have to now document that you do them. And then you can click through those quickly. This is just your standard review of systems, you know, that you all learned in medical school. So you can take symptoms from any of these categories here. You know, in terms of, you know, like neurological, it's common, no headaches, things like that. Musculoskeletal, you're looking for things like, is there cogwheeling, are there tremors, tics, things like that. You know, psychiatric, if they come up with other emotional things, they're still feeling sad, they're feeling anxious. It sounds like it's double dipping, but it's permitted in this case that you can use psychiatric as one of your ROSs. So, again, we have levels. So for problem pertinent, you just need to cite the system that's directly related to their problems identified in the HPI. For extended, you need to get 2 to 9 systems. So for problem pertinent, basically 1 system's enough. If you're doing the complete, comprehensive, high-level evaluation, you need to review 10 systems. However, you only need to document the pertinent ones, and then you use this key phrase. All other systems, look again, reviewed and are negative. Okay? So you don't have to write down everything, you write down what's pertinent to that patient's problem for the day. That'll come up again. So. Now, this is chart forms. It helps you figure out where we're going. And again, brief history. You don't need your past, family, social. You don't need an ROS. This is a problem-focused, what's called a level 2 visit. This is a very low level. You probably aren't going to use that much. Okay, for brief, you don't do the past, family, social, but you do a problem pertinent ROS. That takes you to an expanded problem focus, which is level 3, which is probably where you're going to be a lot of the time. For extended history, you do just your pertinent past, family, social, which is basically 1 thing. You do the extended ROS, which is up to 9 elements, and that gets you into a detail, which is your second highest level code.
I noticed pertinent has an asterisk, no family history, etc. required for subsequent hospital visits. Same
Right.
for the office?
No, in the office, you would have to do at least 1. Usually it's social is usually pretty easy. Social or family are usually pretty easy to do. In the hospital, they assume nothing has changed over the course of the hospitalization. Yeah. Okay, and then the extended, which is your most comprehensive, you're doing complete on all of them, and those would be rare visits for most of us. Or, difficult crisis, falling apart patients would probably qualify at that level. Okay. So, breaking down the history again. I figure if we give you, words, visuals, it all helps the learning. So for HPI, we either do the 1 to 3 elements or the 2 chronics. For our problem-focused visit, for our extended problem-focused, again, you just need the 1 to 3 elements, and you do 1 system ROS. For detailed, 4 elements, or 3 chronic problems, 1 of your PFSH, and 2 to 9 systems ROS. So again, you don't have to document a lot here, but these are things I'm sure most of you do. It's just learning how to put them down in writing. And then, again, your most complex one is where you do need to document more, but these are going to be your very complex patients. And using that all other systems reviewed and are negative caveat for your system review helps you a lot in terms of how much you have to actually write down for your comprehensive ROS. Go on. Okay, so now let's look at the physical exam, which is our single system psychiatric. Keep looking. Okay, so we're going through all of these again. And the ones we're going to key in is psychiatric and what's going to be required for that. So let's go on. Now, this is a CMS schema. I don't know how well that projects. It's not too bad, I guess. What I want you to look at is what they call the shaded boxes, which is the top one, constitutional. This is where you either can do the vital signs or the general appearance of the patient. That is required in the higher level codes. Usually it's 1, except for the highest level code, and you're supposed to do both bullet points. Then you have the other gray shaded box is a psychiatric, which you can see is pretty much your mental status in CMS style, which is your description of your speech, the rate, volume, articulation, etc., your description of your thought processes, logical, illogical, abstract reasoning, your description of your associations, loose, tangential, circumstantial, or intact, your description of abnormal psychotic thoughts, hallucinations, delusions, preoccupations with violence, homicidal, suicidal, obsessional thinking, and description of the patient's judgment, you know, your judgment and insight. And then they call the complete mental status exam, which is sort of like a mini mental status, orientation, memory, attention span, concentration, language, looking more at expressive receptive language, ability to name, ability to retrieve, your general fund of knowledge, and your mood and affect, depression, anxiety, flat, labile, etc. So you do all of this, you just have to learn how to write it so CMS will see that you're doing, or your carriers will see that you're doing this. Yeah.
Do you need to include, I'm a little unclear about this, when you talk about psychiatric or whatever, does it also require 3 vital signs?
No, it depends on the level. You need so many of these bullet points. See the little black dots? Those are called the bullet points. So a complete will require both in constitutional, 1 in musculoskeletal, and all in psychiatric. That's your highest level. Everything else will be less depending on the level. Let's go into that. Yeah.
Does this, in other words, some of these things, is it possible to, in other words, if the patient fills out a form, things like that,
Yeah.
and that it can be entered, we don't necessarily have to, it's documentation
Exactly.
and knowing it, but we
But you
don't
just-
necessarily have to
You
ask,
just say
basically.
reviewed form, pertinent findings. I mean, that's all you really have to do. But you can have the patient fill out one of the, you know,
Form,
path, history.
plans.
Yeah, a lot of that you can do using phone as long as you document and you have it in the chart. You know, review assistance from office visit, you know, 12, what's today, 12/3. There's a 12/2, 12/2. I'm not oriented.
Pertinent.
Yeah, pardon? And, but no, just, I mean, again, this is a documentation game. You just have to be sure you have documented, so somebody's looking through your chart, and you say, oh yeah, okay, it's done, doctor did it. And you reviewed it. You have to just say, you better cite that you reviewed it, otherwise it's just a piece of paper in there, and they have no idea. Okay, so let's break down this physical exam. Constitutional, you said before, is a shaded box, and you have, what's that, 7 bullet points. So usually you either need something, 3 from the vital signs here. So you only need 3 of those. And you know, certainly pulse, blood pressure, respiration are pretty easy to get, or height, weight, respiration, or pulse, or blood pressure, depending. For general appearance, you're looking at development, nutrition, body habitus, any deformities, any grooming issues. You know, kid comes in with blue hair. That's enough. For the psychiatric exam, now if we look at our unshaded box, which is required in your higher code level, you need 1. So it's either muscle strength and tone. You know, certainly you're looking for cogwheeling or Parkinsonian signs in your patients on antipsychotics, or any abnormal body movements, tics, choreothetoid movements, evidence of tardive, or the gait and station. I mean, what's easier than that? Patient walks in your office normally, sits down normally, you've done a gait and station. I mean, it took you, what, 2 seconds? So these things are things you do, you just have to learn to say you did them. Okay, now let's go into our mental status. I think we flipped through those quickly. I did each one individually, but we've talked enough about them, and you know, I think you have them, so, and you all know how to do this, so I don't think there's any science there. Now let's look at our levels for your examination. Now again, you're problem focused, a very low level code. You only need 1 to 5 elements of that psychiatric exam. 1 element, you know, patient's depressed. That's all you need for the documentation. Okay, you want to be a little bit more thorough, expanded problem focused, you do 6 elements. And again, all of this can be taken from your mental status. I think you have 9 elements, or 12 elements, I think, in your regular mental status. I forget how many. But you have plenty of elements to choose from.
11.
Is it 11? Yeah. You have plenty of mental status items to choose, and you only need 6. You're getting into your detailed, which is a higher level code, you need 9. But again, all from your mental status at this point. Only when you get to your comprehensive do you need to go into the constitutional or gate and station. However, with the detailed, you're probably going to constitutional because you're probably describing the patient. Or maybe you're taking some vital signs because of the medications they're on.
Just, I mean, is it okay if let's say, you know, it's a straightforward patient and we want to fulfill the requirements that, like, every visit you're saying patient still oriented ×3 and gate and station still normal? I mean, it seems kind of redundant, but is that
Yeah,
okay?
I mean, yeah,
Okay.
I would tend to use a psychiatric as your monitoring rather than other stuff, especially if you're doing a lower level visit where you only need 6.
Well,
Yeah.
right.
Yeah.
But if we were saying still oriented ×3,
Yeah,
we can
yeah.
say that every visit.
Exactly.
So normal is okay.
Yeah, and normal.
Okay.
Yeah, you can say within normal limits, or no change from last visit, or something like that. What you have to do is say, I examined this system, and this is my findings. Okay, so medical decision making is the biggie because they're in the process. CPT has now formed a work group to look at the E&M codes, and what they're honing in on is what is this process of medical decision making, which is ultimately, we think, going to become the driver of the code. So this is where you really have to start thinking from the time you first see the patient. And this involves the number of diagnoses or management options, the amount of data that you're reviewing, and most importantly, your risk complications. And they're going to hone in on this risk factor quite a bit from the early signs we're getting on, you know, where this is going. So be very conscious of this factor is your patient walks in your office and you're deciding what you need to do for that patient for that visit. And your decision making requires 2 of the 3 to be met. So usually you will meet it on number of diagnoses and or risk. We don't have all that much data to review in psychiatry, although there are ways you can get what we call points for that. Go on. Okay. So how do we get the number of diagnoses and options? What's based on the kinds of problems you have that are during the session. It doesn't have to be a formal diagnosis. It could be a problem. It could be a child comes in with attention deficit disorder and continues to be oppositional. That's 2 problems right there. ADHD, oppositional. You want a 3rd problem? Patient still receiving special services and struggling with language-based learning disabilities. Typical bread and butter child psychiatry patient, correct? How many
Can't
of you
sleep, difficulty with sleep.
Sleep? Yeah. Any of those would would qualify. Sometimes it's the complexity of establishing the diagnosis. Do you need a lot more testing? Are there medical things you have to rule out? You know, the patient comes in sluggish, sad, depression, but could it be hypothyroidism? You have to rule it out. Things like that. So you thinking like a physician. Okay? And the number of management decisions. You know, it's not only do they need medication, do they need to continue therapy, do you need to send them on to some type of other support service, you know, school for child psychiatrists, what kind of school interventions we need to talk to, talking to another therapist, etc. So the more things you have to do to get that patient to a better level of functioning, that's your management options. Yeah.
I may be stepping ahead, in which case you'll answer
Yeah.
the question later, but for those of us who write our notes and have clerical staff then code the billing, how is that going to happen? Are we then coding and telling them what to write on the bill?
Well, ultimately you're responsible, so you need to know, have an idea of what needs to go into the codes and make sure they understand what they have to look for when they code it.
How are they going to know whether it's 2 problems or 5 problems?
You have to write down those problems. You basically have to say,
So we're doing away with narrative notes. We're doing bullet notes now.
it's your choice. You could write a sentence. I mean, you could write it in a sentence. You could write it bullet
No,
point.
because then they have to read it, and then they have to. So we would have to be doing the coding then.
Well, that's something between you and your biller, and your coding person, how they want to do it. You know, as a physician, you write your notes the way you write your notes, and they have to find the data. I mean, when the auditors go through a chart, you know, they're just looking. They have a little checklist, and they'll read it, and they'll say, okay, they met that. So you got to get together with your biller on how they want to do it.
So some people have a list of the codes and they just circle them. You can give that to your biller, you know, that will make it easier. As Sherry's, I think, going to go through a lot of examples that will take us through this, that'll help
Yeah,
us really understand.
yeah, we'll go
this
through some of
better.
it with
And if
you.
you learn how to do it, if you have to hand it off, you can just sort of have a check sheet that they can then go ahead and process.
Yeah, but
Now,
the
a lot of the
NLP is
bill-
gonna have to be responsible for both.
Yeah, I mean, ultimately, it doesn't matter. Ultimately, it falls back on you. This is where a lot of physicians get in trouble. You know, a coder probably brought down from, you know, the administration saying, you know, you need to code more of these services because we can get more money. So they start coding them. But the physician hasn't documented in the record that's what they did. And that's where a lot of the fraud and abuse, like at the University of Pennsylvania several years ago, they were coding everybody as a consultation visit without appropriate documentation. And they got socked several $1 million and all kinds of nasty things. So you, as a physician, you are ultimately responsible for the note in the code. So you have to have good communication between you and who's ever doing your coding for you, that this is the level code you feel makes the visit, and be sure you've put that documentation into your chart, however which way you do it. Okay? One more question, I'm going to go on. Okay?
What about the use of templates?
Yeah, I mean, templates may help you. A lot of people are looking at either making their own templates to help their memories, and we're trying to come up with some that,
You know, Medicare will not frown upon a template.
I don't think so. They're looking that you have documented it and that you've not just checked off. What they're frowning on is a lot of the, you know, click and check and going on where all the notes look the same. And they can't differentiate what's different on this patient. So you have to have a little bit that says this is this patient, and we've done those things. Okay, so let's go on. So other things for diagnosis management options. You get a new problem, an undiagnosed problem. Patient's coming along, been doing okay, and then suddenly they say, gee, since you increased the dose of medicine, I can't sleep. New problem. Or they finally, after they get to know you, say, gee, doc, you know, I'm having some sexual problems since I've been on this medicine. New problem. Then you decide how much you have to work that up versus go on. And you need to refer them for a consultation. Is this problem worsening? All of these factors go into your medical decision making. The more issues you have, the higher your decision making becomes. So, you know, everything is in levels in the system. You know, we have 4 options here. We have minimal, which means everything's great, person's doing great, treatment plan's wonderful. Limited, they're going, you know, pretty much straightforward case, nothing significance going on. Multiple, you have new problems coming up, you have to do more of a workup, there's more management issues you have to check, and finally comprehensive or extensive, and you have lots of stuff going on. You know, patients in crisis coming in, that's what's going to get you at the highest level. You know, patients is suicidal, homicidal, psychotic, falling apart, bipolar, who's rapidly decompensating. You know, that's going to require a more extensive workup. Okay, now, Chinese restaurant syndrome time. How do we figure this out? You know, in charts again, and I think these charts are on the back side. We start getting some of the charts of this. Actually, the history is, the problem points are down here at the very bottom. So, what you do, now remember, this is per problem. So each problem you identify will go through and get a point. So if it's a self-limiting problem, minor problem, stable, improving, you get 1 point. Maximum you can get is 2 points for that problem. Okay, if it's an established problem and it's stable and improved, you can get a point. Okay, an established problem with to the examining physician, but it's getting worse, you get 2 points. It's a new problem, but you're not working it up, you've got yourself 3 points. And if it's a new problem requiring more of a workup, you get yourself 4 points. And the additional workup is not referring the patient for a consultation, but you actually deciding, oh gee, patient's complaining of palpitations, I felt an irregularity when I took their pulse, I better get a cardiogram and see what's going on and then decide whether I need to refer them. You know, that would be you're working it up. You know, if you say, oh gee, go see your cardiologist, that's not going to count. Okay, go on. So again, our levels, just to go over this again, same thing we just said, 1 point for minimal or nothing, limited to 3 and 4. Come on. Now let's look at the complexity. We have types of diagnostic tests ordered. Reviewing old medical records, and this, you know, again would be more important of somebody who just came into your practice, or somebody you haven't seen for a while and you need to get some more reports, updated reports. You know, kids getting updated child study team reports. All of that would count into this. And you just document the relevant findings, you know, for, like say I have a kid who comes in for, you know, just had their 3-year child study team evaluation, and I would just document, you know, whatever was pertinent in that, you know, IQ remains stable, or lost 10 IQ points, or speech language continues delayed, etc. So you just have to show that you reviewed it and highlighted what was important in it. You get history for other sources. Again, this is something that is very important for child psychiatrists because frequently we got the history from the parent or guardian. This also will apply to the, you know, much more of your geriatric cases where you have to get the history from either another family member or perhaps a caretaker. Sometimes it applies to you know, an adult patient. You have an adult patient who's developmentally disabled, can't give you a coherent history. You have to get it from somebody else who is involved in that patient's life. Yeah.
How is that accounted for other than a face-to-face thing? Many times you get on the telephone, you have to talk to somebody.
Yeah, that's pre-post. This is in the office. Somebody comes in the office with them. You know, of course, in kids, you know, somebody's bringing the kid. It's rare that we would see a kid who just shows up on their own, well, under age 17 in New Jersey. You know, a spouse comes in with somebody, you know, say a patient has just been diagnosed with a depression and is not functioning very well. The spouse comes in, and so you meet with part of the session to find out from the spouse's point of view what's going on. As long as they're in the session, then you've gotten your history from 2 people. But if it's before or after, not face-to-face, doesn't count. It goes in your pre-post time.
Doesn't count at all.
Well, it goes in your part of your pre-post time services. Yeah.
If, let's say, someone comes in, they have their old records or discharged from a hospital or something like that, and they're with a spouse, let's say, and give it, is that 4 points because it's 2 2s?
Mm-hmm.
Okay.
Yeah, yeah. Each thing you do is. Yeah.
Say each is.
Yeah. Okay. Let's see. What else do we put on there? Okay. If you discuss the results of a test with the physician who interpreted, so you got, you know, psychological testing. So you say, oh gee, I need to call up the psychologist and find out a little bit what this means here. This does not correlate that well with my findings, so I'm going to find out more about it. You know, that counts because you're probably doing that pre and post. So that will count. But the seeing somebody, getting history from somebody else has to occur during the session. Okay, is that clear?
If you get like a husband on the speakerphone during the session to get information or something.
That's a gray area. It's during the session, but it's telepsychiatry, and I can't give you an, I have no idea on that. I would just document it and say, you know, spouse or whatever participated via speaker. You know, those are still the really gray areas in terms of telecommunications. Now, again, our levels: minimum, none, limited, moderate, excessive. This is the system. Okay, let's look at how we get the data points. Again, you're reviewing and ordering the records is a point. You know, radiology, well, maybe you got an MRI on somebody for something, or an EEG or something like that. You know, that's a point. Any other kind of test in the medical system, or the medical codes. And what will count in this now are some things like giving and reviewing things like Connor's ADHD rating scales, Beck depression, your anxiety scales. If you have the patient fill those out, you review it and you score it, that will count.
Does that include before the session or after the session? That all goes into it?
It goes into it is part of that session. You know, if they fill it out before and they bring it in and you review it during the session, it counts.
But what if you review it before the session or after the session?
You just cite it in your note, you know, reviewed recent Connors and, you know, the score dropped. Or, you know, whatever, depression score dropping. So that correlates with, you know, what your medical decision making is, because there you have some data. You know, just like if somebody ordered a CBC and you saw it beforehand and you would say, okay, fine, your iron supplements have worked, your anemia is now treated, and you make a decision about do you continue iron or what. Any of this that will go into your decision making will count.
How about MMSC? Or
Pardon?
MACA? How about MMSC, mini mental state examination? Is
That's
that part of exam?
That's part of your mental status. You know, that one little section is really a mini mental status. And I think CMS has actually said, no, you can't count that because that's part of the system exam. So, let's see, what else do we have here? Okay, obtaining history from someone other than the patient is a point. Well, the decision is a point. When you actually obtain the history from someone other than the patient, or discuss it with another healthcare provider, you get 2 points. So if you call up and have to talk to the therapist or something, that's part of your data points in this. Yeah. Yeah, that's another healthcare provider on that patient within that 24-hour pre and 7-day post. As long as it occurs within that time frame, it counts towards that level of visit. Okay?
But on this problem point, when you said before, like the thyroid of the patient and you get blood work, so do you have to document it as a separate problem point? Rule out thyroid illness, rule out anemia, rule out Lyme disease. Are those all separate problem points with different values and you have to rate out each one for every lab you're getting or something like that?
Well, you write it as part of your differential to document why you ordered the labs. Because, again, you
can't
have
just write labs anymore.
Well, to a certain extent. You have to document medical necessity. You can't just say, oh, I'm going to get a lot of data points. I'm going to order 27 lab tests, and I'm going to get myself lots of data points. No, you have to have a reason why you ordered those tests. They're going to come after medical necessity quite a bit in this. So again, these are the things you have to be careful of. Your medical decision making is based on medical necessity for that visit. You do what you need to do to take proper care of that patient.
It seems to me when you cite each visit, you have to put down how many data points for each visit.
You don't have to, no.
You're going to give it to someone to
Now, it has to be
process.
easily identified in the medical record. How you're gathering this, these are guides for you to figure out what code you're in. Did you fulfill? Did you review? And as long as your record shows that you met with somebody other than the family, which you probably would put in your record, the visit, reviewed labs, reviewed, you don't have to write down every lab, you have a list of labs that you ordered, and you say reviewed labs, abnormality, abnormals here. That's all you really have to do, but I suspect a lot of you would do that anyway. It's just a matter of putting it in a format so somebody else could say, oh yeah, okay, this is how auditors score you. This isn't what you have to do per se. This is for you to have that schema in your head that says, okay, I did all these things, what code best meets it? This is what this whole thing's about. Yeah, a couple more questions and we're going to go on, because I know this is complex.
Multiple lab tests, CBC and Kenzyme, is that 1 point? In other words, it comes on one thing.
Yeah, that's reviewing labs, yeah.
Labs as well.
Yeah.
History obtained from someone other than the patient can be family member who brought the
Yeah,
patient?
oh yeah. I mean, very common in child psychiatry. We do this all the time. And, okay, two more questions and we're going to go on, because I think we're going to cover some of this, yeah. Okay, who's first? The lady in the middle, we'll be fair.
With regard to, this is documenting within the session, so the only outside conversation that can be documented with regard to in the session is a discussion with another healthcare provider about lactose.
Or anything, the therapist.
So that's not pre or post?
Yeah, no, but if it occurs before or after, within 24 hours of seeing the patient or 7 days after, it's part of your pre-post time.
Okay.
So,
There's a discrepancy between history from other sources, and you said in the office versus
Yeah, it's two different data points. You get 2 points if it's within the office. You get 1 data point if it's just getting it from elsewhere. You get 2 if it's a healthcare provider. Did I have that right? Yeah.
Yeah.
Okay, one more. Who hasn't asked a question? Okay.
Typically I generate a CPT code in the session, like right at the end of the session.
Yeah.
So if you have this stuff about 7 days post, do you think it's not possible to do that anymore? Or
No, because you can say, we'll talk to the therapist. We'll put a call into the therapist and just document your record that you talked to the therapist within that 7 day. I mean, you just go back and say, spoke to so-and-so about this. So you have it in your record, yes, I did speak to them, and it's within that time period. That's all. They're not documenting, they're not going to come by every visit. They're going to look at the chart. So as long as the chart makes sense. Okay, let's go on, because we can get bogged down in this point counting stuff. Okay, so let's look at complexity of data. Again, we have your data points. You get 2 data points, it's limited. You get up to 4, it's an extensive visit. And that's probably going to be a pretty sick patient for that visit. Okay, risk. This is a biggie these days. And you have to, it's based on what your presenting problem is. Obviously, if the patient comes in suicidal, that's your presenting problem, that's high risk. We're not doing diagnostic procedures. And we have to look at the number of management options we're dealing with for that visit, okay? And the highest level of risk is what determines this category. So you pick the highest level, and that will drive your risk medical decision making, okay? Now, this is the risk table. It probably doesn't project that well. I hope it photocopy better, but maybe not because it's so tiny.
Is this available online?
Pardon?
Is this available online?
Yeah, this is from CMS basically. So this is the stuff. The important things are what we've talked about, the level and the management options. We don't do much in the way of diagnostic procedures that would meet a high risk thing.
Where would you get this table?
Pardon? CMS.gov. Yeah, a lot of this. I mean, basically it's all in here. This is just how they schematicized it. So it's, I think the information is all in here. So let's move on. I just got my 5-minute warning on this, so let's see if we can get through a little bit more. This table, again, kind of summarizes it better for you in terms of where you're at. Look at the red one. It's a moderate level of risk because we have 1 or more chronic illnesses with mild exacerbation, progression, and side effects. That's probably kind of common in a lot of our visits. Or we have 2 or more stable chronic illnesses. So those 2 points are probably pretty common in a lot of what we do. Sometimes we pick up an undiagnosed new problem. Occasionally there might be an acute illness, such as say, maybe a strep infection with a kid with OCD, which could be exacerbating it. So those are the things that put you in there. And your management options, prescription medication. So when you're writing and monitoring medication, you're already at moderate risk. You're there. And then, of course, if it's more complex, you're getting into your high-risk drug monitoring, intensive therapy like Clozaril, things like that, where you have to monitor very closely. So that's where those are the things that push you into the high risk. The bulk of your patients are going to be moderate. So if you just focus on making sure your decision making is at that level, you're going to be there. That's going to satisfy your code levels. Yeah, one more question, because we want to get through a couple more things before you break. Okay?
Just the understanding, rather than talking, what if the risk is unknown? So I take care of a lot of pregnant women.
Yeah.
And I go over all of the data that's out there and help them make that decision. That's very intense,
yeah.
But it's, I don't know if it's high risk, it's just educating them. A lot of it is unknown. So would that make it a high?
Yeah, I think you're pushing into high risk just by the number of things you have to advise them with. In terms of their medication, the effects of stress, depression on a pregnancy, all of that stuff. Because the outcome, what's the outcome? The outcome is going to harm the baby.
Right.
And or complicate the delivery. Those are significant situations. So yeah, that level, I think, especially the amount of time you spend, you're getting into the high level. Okay, let's go on. Wait, 1 minute? Okay, let's see if we can get one more slide and then we'll stop, okay? Okay, Why is the medical decision-making drive the code? 2 words, click. Medical necessity, which we talked about. So that's the thing that always has to be behind what you're doing. You can't just do to get a higher code level. You do because it's medically important. Okay, I think we're going to stop here. Take a, maybe, why don't we look at about a 5-minute break? And then we can continue.